All right, welcome everybody. It's Thursday, but it's our Friday, according to the way class works in the summertime. So I am going to go ahead and get started, but I want to check in before I begin the lecture. Oops. Does anybody have any questions about the material that we covered yesterday before we get started? Okay. All right. So we were talking about these 6 pathways that either psychologists or other allied health professionals can do that are win-win-win. They improve quality of life for their patients. They save money. They're easy and cost-effective to provide. And the last one we covered before we ended yesterday was social support. And we gave the dual example for women in labor. The next pathway, pathway 5, is considered to be the undiagnosed psychiatric or psychological disorder problem pathway. And so this is where individuals who are under so much distress that they qualify for a psychological disorder, who access healthcare and fall through the cracks in healthcare. So they're not getting what they need because they're not getting correctly diagnosed. So these would be people who aren't going to a mental health professional. They're not going to a counselor, social worker, psychologist, that type of thing. And so let's first start talking about Claudia's thesis. This is a thesis that was in our department years ago. Dr. Kurt Michael chaired it. I was one of the committee members. And Claudia was married to a man who was an ER physician in Watauga Medical Center ER, but he aspired to an academic career. And so Claudia got the cooperation of this listserv for ER academic doctors, and they ended up being the participants for her thesis study. And what she did is she created these vignettes, which are these little stories that you read. And then if you're a participant in that research, you read the vignettes and then you answer different questions based on them vignettes. And what she had was a vignette that was, the design was either the person in the vignette was a male or female. And then the person in the vignette either had all of the diagnostic criteria for NDE is major depressive episode, so depression. So she's got male, female, target. She's got major depression or panic disorder. And she got these ER physicians on this listserv. They got a link to the survey, and they all got randomly assigned to one of those 4 conditions. And when they got the survey, they read about this particular potential patient in their ER. And then she had consensus after they read through the vignette. She had a list of the diagnostic tests that most ER physicians would order. And so these diagnostic tests went out, they came back, and they're all negative. So as an example, this person who looks like they might be having a heart attack is not having a heart attack. Then she had the physicians, after they read the diagnostic test, they had to make a diagnosis, and then they had to create a treatment plan. And what Claudia found is that when the target patient that had depression, so they had the characteristics of depression, 72% of the ER doctors correctly diagnosed depression. And so that what that means to me, if we do the math, 28% of those ER doctors missed the major depression. Does that make some sense? So it wasn't a heart attack, but if you looked closely, it looked like this is a target patient that has depression. So 28% of the depression cases got missed. 33 of the panic disorder cases got diagnosed correctly, which means almost 70% of the panic disorder diagnoses got missed by these ER doctors. When I was in her thesis defense, because these doctors had to make a diagnosis down at the bottom of the survey after they read and they saw the negative test, that kind of thing. And I remember thinking, wow, like almost 70% or 68% of people miss panic disorder. What was their diagnosis? If it wasn't a heart attack, what were they thinking it was? And the main thing that the physicians were putting for diagnosis was tachycardia. And tachycardia means high heart rate, right? It's just a symptom, just high heart rate. And we got the giggles in Claudia's thesis defense because and then it was tachycardia, and then there was no treatment, there was no referral, no treatment for it. They were just discharged from the ER saying, good news is you haven't had a heart attack. And we got the giggles mainly because, what if the diagnosis was hemorrhaging? Can you imagine an ER doctor having a patient come into their ER and they're bleeding out, and they write in their chart, yep, they're bleeding, they're hemorrhaging, I'll discharge them now, not stop the bleeding, not treat the bleeding. But this is a good example, at least of a hypothetical case using the vignettes, of where these patients with these psychological disorders fall through the cracks. Any questions about that? And when I use that term, fall through the cracks, and what that means? Okay, let's look at the second study. The second study actually involved real ER department patients. So these are real people that have presented to the emergency department. They're having chest pain. They're concerned that they're having a heart attack, but the myocardial infarction, the heart attack gets ruled out. And then they gave all of these patients a one-page psychological disorder screener. I'll talk a little bit more about that here in a minute. And what they found was that of those people that thought they were having a heart attack that were not having a heart attack, 17.5% of them met criteria for panic disorder. 23% of those individuals met criteria for depression. And so what this is starting to tell me is that we're seeing depression and we're seeing anxiety, particularly panic disorder, is a frequent flyer in emergency departments, but in a lot of situations, they're not having a heart attack, they're not having a stroke. And if they get identified for what's really going on with them, then we've got wonderful treatments that we can refer them to. Depression's treatable, panic disorder is easily treatable. We've just got to identify these individuals in order to get them referred to the treatment that they need. The last thing down here is the Prime MD. And the Prime MD, I've used this in my clinical practice. I've used this when I've had students of mine, or I've been supervising somebody who's in a cardiac rehab program. And the beautiful thing about the Prime MD is it's a one-page paper and pencil survey. It takes people like less than 10 minutes to fill it out. And what you simply do on the Prime MD is you check symptoms, and there are a bunch of symptoms on the page. You check symptoms that you've had within the last month, and they're clustered. There's a way to score the scale, but they're clustered in a way that, depending on the counts for how many checks they say, yeah, I've had this symptom in the last month, it screens for the most common psychological disorders. So again, it's like this 10-minute little assessment that can tell doctors very quickly what probable psychological disorders this particular patient has. And it's called Prime MD for a reason, primary care for MDs or DOs. And in this particular study, this was more of a hospital surgical study. What they did is they had all of these patients that were scheduled for a non-emergency surgery in their hospital, and they just gave the Prime MD to everybody. They scored it. And anybody who flagged for a psychological disorder on the Prime MD, they gave them brief psychotherapy for whatever psychological disorder or issues that they were having. And what they found is that the program to do this screening and to provide these services to these patients cost them $40,000 a year to do that service. But it saved the hospital $270,000 in expenses or costs that they could not recoup from insurance. Now, I want us to think here for a minute. That's a really nice return on investment, by the way, just picking up these psych patients who were under distress before they went into surgery, giving them some brief psychotherapy before they went into surgery. Does anybody have an idea of how they could save money by doing this, providing these services?
You can make it to where they fill it out on a screen instead of like on a sheet of paper. But you know what I'm saying?
Yeah.
You do it through technology, and you wouldn't have to print out pages and look through them like that.
So nowadays, if they did this intervention, because this was done a while back, they probably have people do it on like an iPad or a tablet. Yeah. But how do you think, if you spend $40,000 doing this service, any idea how it recoups $270,000? So almost is that sixfold? It's hard for me to do math when I'm lecturing, but a huge increase in savings. I'll give you an example for this. Okay, so let's say that you are a real unhealthy older man, and you get a diagnosis of pneumonia, but you're a cigarette smoker, you don't eat well, you don't exercise. And then let's say that hospital, they bill a code for pneumonia. And that code pays X amount of dollars to treat pneumonia. But that gentleman, they are likely going to have to keep in the hospital beyond what the normal pneumonia code pays for, because he's got other health issues and they may end up losing money on him. Does that make some sense? If you're unhealthy. if you had, let's say, one of you all in class, a young, healthy college student, contract pneumonia and have to go into a hospital, and they bill your insurance company for a pneumonia code, but you're so healthy otherwise that after they give you antibiotics, they discharge you a day early for the amount that the pneumonia code pays. They've saved money on you. Does that make sense? They've saved money and they've profited on you. And who in here has watched New Medicine documentary yet? Anybody? Okay. There's a scene I want you to pay attention to. It's Glazer and Kegel Glazer. They are a virologist and a health psychologist. They're actually married, but they work together in research in a team. And one of the studies that they did is they examined these older individuals who were not caretakers of Alzheimer's patients compared to these older individuals who were caretakers for Alzheimer's patients. And they administer a standardized wound, and the wound is about the size of a pencil head in the arm. And they watch the wound healing. They track the wound healing in these caregivers versus these non-caregivers over time. And what they find is that those who are caregiving for Alzheimer's patients takes those wounds a long time to heal. But those who aren't caregiving probably have a lot less stress in their life. And when they're administered a standardized wound, those wounds heal much more efficiently. And so somewhere in this, if you are stressed and distressed and you go into surgery, whatever codes they're using to bill, you might end up staying longer and costing that hospital more because it's going to take you a long time to recover. If you were this stress-free, happy, healthy person and you go into surgery, your wound healing is going to happen very quickly and you are likely to be discharged from that hospital, and they're going to be given a profit for whatever diagnostic codes that they use for you. Does that make some sense? How all this saves some money? Okay. Okay, the sixth pathway, somatization disorders, is a whole entire section in the DSM classifying the psychological disorders. And so somatization, the term literally soma means body. And so somatization disorders are when individuals truly have a psychological disorder, but the psychological disorder is getting expressed in their body through what seems like physical illness. Okay. So in some situations, this could be something like chronic pain. It could be things like irritable bowel syndrome. Chronic fatigue is a common somatization disorder. And these somatization disorder patients are frequent flyers in the healthcare system, and they're frequent flyers to emergency departments also. And the problem is that they've got this distress. They feel it legitimately in their bodies, like their bodies are tired or their bodies are in pain, and they keep accessing healthcare, and they go to a lot of specialists, and they go to the ER, and they go to these big teaching hospitals. And unfortunately, the doctors are looking at what organically could be causing these symptoms, and they do the test and they do the blood work, and it usually comes back negative. And they oftentimes then they'll discharge these people like, I can't find what is wrong with you. And again, a lot of these somatization disorder patients, then they fall through the cracks. And the sad thing about that for them is these are individuals who really are suffering. I mean, it may be more psychologically driven, but they are suffering. You know, even their physical illness is going to create more psychological distress. And so if they get missed, if they fall through the gaps in the healthcare system, they don't get the treatment that they need either. But this gets a little more confusing. We just talked about depression and panic disorder falling through the cracks. In this situation, you've got people that are complaining of these physical kinds of symptoms. So this gets even more confusing for doctors in making this diagnosis. So in this is just one study. Keep in mind, there's a ton of research on how to capture, diagnose, and how to manage somatization disorder patients. In this one particular study, what they did is they had primary care doctors use the PrimeMD on their patients. And if they were flagged for somatization disorder on the PrimeMD, the primary care doctor did a very simple intervention. It was to invite that patient to schedule an ongoing weekly medical visit in their primary care clinic. And many of you all are probably sitting there thinking, well, that sounds expensive, but it works. So you had physicians sit down a patient and say, yeah, Mrs. Smith, when I have to work you in my schedule, when, you know, you call in the morning and I don't have any appointment times and I have to work you in, I don't have the time that you deserve for me to really sit down and listen to you and to talk with you about what you're going through and see if we can problem solve some treatments for you that could be helpful. How about you schedule a weekly appointment? You pick the time that is best for you. You can ask the receptionist out there, morning, you know, afternoon, and I will see you once a week. You come in, bring your list, you know, like your list of symptoms, and we will sit down and we will problem solve together. And that intervention works. It has, in this particular study, it decreased medical costs for those patients by 30% in the following year. And probably the way it works is that these individuals are getting believed about their symptoms, and then you've got somebody who is giving them at least 15 minutes of sustained attention every week, a professional, and they're problem solving. And sometimes in that more sustained attention and problem solving, they actually come up with more types of solutions there. Okay, I'm trying to flip my grid over here. Any questions about that? And I'm going to give you a fresh off the press example of a hit home example of this. This is Amaka Emo. She was my honor student that just graduated in the spring. And I'm going to summarize for you, but this is her poster. I just want to give you an idea. This is what her poster looked like, but I'm going to summarize what she studied. She surveyed individuals who were doing extra credit on SONA in psychology, and she surveyed women only. And she asked these women about a history of victimization. So verbal abuse from family or others, sexual abuse from family or other. She looked at rape. She looked at physical abuse from family, physical abuse from a partner. And she took all of those interpersonal violence victimizations and she added them up to a total score. And the total score was deemed to be polyvictimization. And what she looked at in these college women who had reported polyvictimization, if you go down here, you'll see 47% of these college students, so this could have been some of you all in the class participating in this study, 40% of these women reported at least one victimization kind of interpersonal violence. 46% of those who had one form of interpersonal violence had polyvictimization. Okay, so basically there was quite a history of interpersonal violence and polyvictimization in these college women. But then what she did is she had a DSM domain screener, so it screened for psychological disorders, and you see the ordinary stuff down here: anxiety, depression, somatization. And she looked at which of these was correlated with that polyvictimization, and any of these down here that were correlated with polyvictimization, she entered into a regression equation. I can give you the main results. The two major things that trumped all of the other psychological diagnoses in a regression related to polyvictimization were somatization, so feeling like your illnesses are not being taken seriously or feeling like you've got illnesses that are quite serious. And the second thing was suicidal ideation. And so what this kind of told us is that the physicians and nurses in our health center, when they have women who are coming to them and are reporting these physical kinds of symptoms that look like a medical disease, that they do the testing and the blood work and they rule it out, they should be ideally screening their patients on a regular basis for a history of trauma or a history of interpersonal violence, because it looks like quite a few of those cases that show up as somatization are really associated with a trauma history. And then from a suicidal ideation standpoint, ideally healthcare providers should know how to screen for that and intervene for that. I can tell you that Dr. Kurt Michael and Dr. JP Jameson on our faculty, they have been training resident advisors, RAs, in how to screen and intervene with suicidal ideation. So we do have some programming that's going on our campus. And of course, everybody, all the professionals at the counseling center know how to do that. So any questions about that research, about somatization disorder? And then we've got kind of a modern example of what's going on in our college students. Okay, then let's switch gear and let's move. We've gone from those 6 pathways now, and let's move over into behavioral interventions for mental health. And this is the Walsh article that is up on As You Learn. I would love for you to read it if you haven't already. And he talks about these 8 therapeutic lifestyle changes that to me, they should be called ordinary lifestyle behaviors, but so many people are not doing these things that they would require change to be doing these things. So he calls them therapeutic lifestyle changes, TLCs. And he says that these recommendations are being underutilized by healthcare providers. And we talked yesterday about that whole domino effect from the nurses' health exam study where 1% of the nurses followed the healthy lifestyle. And he suggests that if we know these things work scientifically, we need healthcare providers regularly assessing for these TLCs, recommending these TLCs in their clients, and then ideally delivering to them counseling for these different TLCs. And we're going to be integrating this stuff all semester long, throughout the semester. So let's go ahead and launch into them. The first TLC, exercise. I like that he put this at number 1 because this is a very powerful intervention for mental health patients and for medical patients that we are not on a regular basis advocating exercise in our patients. And he talks about how exercise benefits multiple bodily systems. So it's really great for us physically. He talks about how beneficial exercise is in mental health. There's a push in the psychology field. We screen and we recommend, as long as somebody doesn't need screening by a physician, in which case we will send them, but how beneficial exercise is on so many different levels for our mental health. And in this particular study, he reviews studies that have shown it's beneficial for depression, it's beneficial for cognitive decline, it improves memory. We even know all the way from elementary students to college students, you learn better. You learn information and you cement it in your memory better if you have been exercising while you have learned that information and have slept on that information. If you've been exercising around that, you are going to remember that material much longer than a student who is learning the material the same way but not exercising. And so it improves memory and it reduces cognitive decline, so it helps prevent the development of Alzheimer's. We know exercise is absolutely fantastic for treating anxiety disorders, and that makes perfect sense for me. Our bodies, I love how Walsh puts all of this into an evolutionary context. Our bodies are wired to move a lot because all throughout human evolution, we have had to move a lot for survival, to hunt food, to scavenger for food, to run away from prey. We're wired to move. And you take a body like that, that is wired to move, and you just put it down into a sedentary lifestyle where people don't move at all. It makes a lot of sense. You're going to have consequences. You're going to have physical consequences and you're going to have mental health consequences. There's data to such how helpful exercise is in treating addictive disorders across all age groups. So good stuff. The second TLC that Walsh recommends is food and nutrition. And I love how he has this term rainbow diet. And rainbow diet meaning that across the food groups, but especially with fruits and vegetables, we're going for foods that have really high pigment, are very colorful, have lots of pigment in them. And we even believe that one of the reasons why we human beings have evolved to see in color, because a lot of our fellow mammals do not see in color, is that by seeing in color all throughout human evolution, we learned how to forage and find foods that would be super healthy for us and help us stay alive. So those highly pigmented foods they're nutrition dense and they're very good for us, okay? So he talks about the rainbow diet, particularly in fruits and vegetables. He also talks about the benefit of fish and omega-3 fatty acids. And then he has talked about the research looking at associations between reduced calories, reduced fats because of reduced animal products, and has shown that people that don't eat as many of those animal products have better cognition, better memory. They do better in learning and academics for both kids and adults. They even have less vulnerability for schizophrenic and affective disorders. And then he's talked about the Mediterranean diet, which would be like brown rice, lots of vegetables, olive oil, wine in moderation, and how effective across different research studies the Mediterranean diet has been in reducing neurological conditions like Alzheimer's disease and Parkinson's disease. So I'm curious, how many of this information, how many of this was new to you? I know we've got some nutrition people in the audience that I bet this wasn't new to you. Anybody? Okay, let's keep going. A little more detailed information on recommending supplements for individuals who are vulnerable. And he talked about using fish and omega-3 fish oils. Again, for individuals who are who have affective and schizophrenic disorders, this is a real simple thing that is not happening. I can tell you, I supervised for a while a psychologist at our local emergency department, and their job in the crisis team was to take these patients who came in who were having psychological distress and diagnose them and then figure out treatment for them. So in a lot of situations, they had to hospitalize these individuals because they weren't safe for themselves and safe for others. But rarely were the doctors that were seeing them in the ER simply prescribing some nutritional supplements that the science suggests is really helpful. So unipolar depression, bipolar depression, schizophrenia, perinatal would be surrounding pre-birth or postpartum for women suffering from depression. These very simple food supplements. Now, ideally, my nutrition people would say, hey, get this stuff in your diet. I know that. But if people aren't getting it in their diet, it's very easy to prescribe a supplement, have them take a supplement that can, according to this research, work wonders in helping people with their mental illness issues. We also know in children and teens, these supplements help reduce aggression. They help reduce ADHD symptoms in individuals who have ADHD. And they've even been shown to prevent the onset of psychosis in people vulnerable to schizophrenia. So schizophrenia, if you've got a genetic history of it and you are in your teen years or early 20s, and so there's the possibility that you could have your first psychotic episode and become full-blown schizophrenic because of the family genetic loading. Why are we not recommending that those individuals follow really healthy nutrition and consider these supplements? If it's that powerful that they can sort of break the onset of psychosis, that's really valuable. If I had a genetic predisposition for schizophrenia, I would definitely be on all of this. Any questions there about the benefits in food and nutrition? So we are what we eat, so it makes a lot of sense that our mental health is we are what we eat. Some other things that he talks about in terms of supplements, vitamin D, the scientific community has come a long way in the last decade on understanding how beautiful vitamin D is for us. And I know with my patients, I recommend on a regular basis that they try to get out and get 10 to 15 minutes of direct sunlight every day, because we make our own vitamin D. We just need some sunlight to help with that. This is part of the reason why a lot of us, like in a really long winter and boom where it's been gray and we've been cooped up for a long period of time, everybody feels kind of blah. And then the temperature rises and the sun comes out and you all are out on the lawn at ASU and you're all like, the sun gods, I'm absorbing vitamin D and feeling better, even though I don't know that's what I'm doing. We know the power of vitamin D. It's a neurotropic. It really helps us lay down memories and think clearly. It's an antioxidant, anti-inflammatory. So that's good in terms of capturing cancer and pulling cancer out of our body. And then from the anti-inflammatory standpoint, a lot of times we think about inflammation as creating havoc in our joints, but there are neuroscientists, excuse me, nowadays that are thinking every psychological disorder is really an inflammatory process in the brain. And so the idea that inflammation is driving depression, it's driving anxiety, it's driving schizophrenia, bipolar disorder, that is really important. And so we'll talk a little bit more later on in the semester about the power of inflammation in the body, but I just want you to know that vitamin D is very helpful with that. We also know in people who have cognitive impairment, people who have depression, bipolar, and schizophrenia oftentimes have very low levels of vitamin D. And so again, psychiatrists who are medically treating these individuals, primary care who are medically treating these individuals should be doing the blood work and taking a look for this, and then encouraging individuals to take supplements, eat foods that are high in vitamin D, get that 10 to 15 minutes of sunlight a day. Okay, so diet that's good for the brain is good for the body. Number 3, nature. My bet is excuse me, many of you who've come to ASU did so because you love nature and you love being able to get outdoors and enjoy the beautiful scenery that we have surrounding Boone. And so I love this quote from Walsh: "Imagine a therapy that has no known side effects, was readily available, and it can improve your cognitive function at zero cost," and that would be nature. And Walsh talks a lot about how many of us live in these artificial environments nowadays, when if you think about human evolution, it's only very recently in history that we lived in homes, that we lived underneath artificial light, that we lived on computers with this different kind of weird light, coming at us on screens. We lived out in nature, most of us, and slept somewhere secure at night across human evolution. So he talks about how noise takes its toll on us psychologically. I know a couple winters ago, I took my family, we went up to New York City and had a lot of fun in New York City, and it was really great. But the noise, the cabs that are honking, and the buses that are going by, and the people that are talking, and just all the sounds. I remember getting back to Boone and just going, oh, like that was really fun, but I am so glad to be home and just have peace and quiet again. Also, in terms of thinking about the artificial lighting, and we know that that most of us are not exposed to normal natural spectrum. That's part of that getting out and getting sunlight every day. That people who live in these artificial environments have poor attention span, problems with their sleep, problems with their long-term learning and academics. And then he has this term called technopathologies, which is his term of like people being on phones and being on screens, and then watching TV maybe, and just always being involved in technology, of how that starts to create havoc on our physical and our mental well-being. Okay. So that media immersion that we've talked about does tinker with our attention span. And he has this thing that he calls cognitive digital fog, where after we've been immersed in this media and we try to like think about normal things in life, a lot of us are just kind of like, it almost like makes us a bit dull and stupid there for a bit. He talks about overload and frazzing. And overload and frazzing would be the way we are wired. We can only really pay attention to one thing at a time. And so an example would be we can drive and we can think, we can drive and we can listen to music, but we cannot drive and talk well on the phone. We cannot drive, and we especially can't text while we drive, because you're either paying attention to the texting, the reading it, or the actual typing it in, or you're paying attention to the driving. We can't do both. And so he calls that frazzing, where in this very busy society, we're trying to multitask, but we're not doing it very well. And I want to spend a moment here and talk about how, in a bit in this semester, we're going to talk about stress management skills, and we're going to spend a lot of time on mindfulness. And one of the things that mindfulness activities does for us is it brings us into the here and now. And we get very focused on one thing. So one mindfulness relaxation exercise might be focus on the here and now. And all we do is focus on our breathing in and our breathing out. We're just focusing on this one simple thing. And when we do that, our whole mind and body chills. The flip side of that is when we're frazzing, when we're trying to multitask and we're trying to do these things, we're not doing them very well. And it gets very stressful for us. Our bodies get really hyped up trying to do these multitasking things. And then we get frustrated because they're not going smoothly. So I just want you to know that this kind of stuff is the opposite of the mindfulness and the meditation and the stuff that we're going to talk about later. We know that there are even individuals getting addicted to gaming and online types of things. And I can tell you that these programming companies that make these games, they hire psychologists, because the psychologists get in there and they help the programmers program these apps and these games, making sure that they have these variable reinforcement or intermittent reinforcement schedules that keep people wanting to play. So like, imagine this is me, I don't play games on whatever that thing is. But anyway, here's me playing, let's say. and it's way past my bedtime and I really should go to bed, and I am just so close to moving up to the next level, whatever that next level is called, and it's like, oh, I got to make it to that next level, and they keep playing. So they're playing for that additional reinforcement, if that makes sense. So he calls it screen sucking, people getting sucked in, that kind of stuff. The hyper reality is when individuals are watching, as an example, round the clock news, or they're watching around the clock reality TV like the Kardashians, and then getting this sense, because that's their reality of what's going on these other people's shows or on the news, getting this idea that that is what life is like. Okay, instead of living their personal life, they're living life on screen, and that gives them this sense of this kind of hyper reality that that's real when it's not really. Okay, any questions or comment?
Question.
Okay.
About the like having people come in, like, I don't know if this is a dumb question or not, but like, is that considered like ethical to have people like working to like enforce an addiction for like having people come in for the games?
There are a bunch of lab studies that actually study people playing games, but what I'm getting at here, this isn't necessarily an experimental manipulation, although that has been done. A lot of times what they will do is have people somehow keep track of how long they're on screens or how long they're playing video games a day, and then look at their psychological health and compare them to individuals who report that they don't engage in any gaming or have limited screen time during the day. So it's kind of naturalistic, Emily, if that makes sense. And then finding that we know that these people that spend excessive amounts of time doing this stuff psychologically are not as healthy as individuals who limit this stuff. And especially if you limit this stuff and you spend more time in nature, if that makes sense.
Yeah.
Yeah. Have you all experienced this where I hear this. I hear this more from my graduate students right now. When they were trying to finish out screen semester, they were like, oh my gosh, I'm Zooming in class. I'm on my screen all day. I'm doing my own work. I'm Zooming with my family. I'm so sick of looking at the computer, kind of thing. Have any of y'all had some of that? Like now it feels excessive because this is not what you were doing in real life before? Yeah. I think a lot of people are feeling that. Yeah, I'd much rather be in a classroom teaching with real students, spending a little bit of time on my computer, seeing family in person kind of thing than that. So both of this, some of this research is experimental studies and some of this is more naturalistic studies, but pay attention to that in the Walsh article. He explains the nature of the science where he's presenting these results. Anybody else, any other questions? Okay. I love Walsh's term, nature deficit disorder, that what a lot of people are suffering from, they're spending too much time in artificial environments, on screens, in artificial life, and they're not out in nature. And I'm going to play this for you. I want to make sure my screen share keeps working. Can you all see this?
No.
Okay. I keep learning this. I have to stop share the PowerPoint. Thank you for letting me know. And then I come over here. And then I screen share. Again, I'm talking myself through this, y'all. Okay, here we go. Best drug commercial you'll ever see.
Do you find yourself longing for the apocalypse? I did. I was looking for a reason to live. Hi. Are you feeling tired, irritable, stressed out? Well, you might consider nature.
From the people that brought you Getting Outside comes prescription strength nature. a non-harmful medication shown to relieve the crippling symptoms of modern life.
Nature's recommended for humans of all ages, and it's great for pets too.
Nature can reduce cynicism, meaninglessness, anal retentiveness, and murderous rage. In clinical studies, nature is proven to decrease work-induced catatonia.
Caution, nature may cause you to slow down, quit your job, or seriously consider what the you're doing with your life.
If you are overly cynical, jaded, or emotionally numb, you may need to increase your dose of nature. Do you have trouble being even mildly uncomfortable? Nature may not be right for you. Side effects may include spontaneous euphoria, taking yourself less seriously, and being in a good mood for no apparent reason.
So ask your doctor if nature is right for you.
Yay, nature. I hope you all enjoyed that. Okay. All right, back to the PowerPoint. And indeed, when you look at the science of people who spend a lot of time in nature, you find just such a beneficial effect. Let me close out that. Beep. Go away. Okay. Nope, I don't want that. Here we go. Oh, did I get it all? No, I didn't get it all. We know that time in nature enhances our cognitive capacity. So for those of you all who are students, I don't know if you had this experience where you're studying, and then you got out and you took a nice hike, you know, somewhere maybe off the parkway or somewhere surrounding Boone. And then you come back and you feel like you've had a little mini vacation and you feel like you can think clearly again, or you feel like you've got the attention span where you can study a little bit more. That's the kind of stuff that we're talking about here. We know that it lifts mood, improves the length of our attention span. For a lot of people, feeling that sort of spiritual connection with nature of how beautiful it is. I live on a road on a river, and I ride the road, try to do it all season long. And I find it to be just especially kind of a spiritual, meaningful thing just to watch the seasons change as I ride on the road all throughout the year. It's pretty cool. And so another thing that nature gives us is that gift of silence, sort of hearing, you know, maybe ducks quacking or crickets at night, or I don't know if you all have fireflies, but I love seeing the fireflies come in the summer in the evening. That all of that, just that kind of quiet and those natural sounds as opposed to those unnatural sounds like horns honking in a big city, that type of thing. We know that this decreases our stress, it improves depression, it improves ADHD symptoms in people who have that disorder. So pretty valuable stuff here. Any questions about the nature before we move on? Can you all relate? Can some of you in here relate with how good it feels? Yeah, cool. Okay, so the fourth TLC from Walsh is relationships. And remember, I've talked about how I feel like quality of life should be the outcome in any healthcare research, because after all, don't we want people, if in healthcare, don't we want to be able to improve their quality of life? Isn't that sort of what providing services is about? And we know that the majority of our quality of life, of that variance in predicting quality of life, is our connection with other people. And so especially when it comes down to this construct of emotional intimacy, so not necessarily talking about sexual intimacy with people, but emotional intimacy, do you have people where you can share your stuff with and they will understand, they will listen and be empathic, and they will understand, and then they feel like they can share their stuff with you? That's emotional intimacy. And we know that quality of life, as predicted by that emotional intimacy, predicts happiness and improves happiness. Our resiliency, a lot of us are practicing resiliency right now. Resiliency is when we are stressed or we are going through something brand new in life, some kind of adversity, is our ability to actually try to cope with it, and ideally cope with it and arrive on the other side as a better person, where we've actually kind of grown from it. A person who's not resilient would undergo stress or something brand new in their life, and they would be struggling. It would be taking them down in some way. We also know that emotional intimacy and that quality of life predicts our cognitive capacity. We can think clear, we can learn better We can make better decisions when we feel like we are secure in our relationships. So, knowing this, when we start talking about psychopathology, which would be going back to DSM and abnormal psych, people who have a psychological diagnosis, that is usually associated with lower quality of life and lower intimacy in their relationships, okay? And so it's no wonder that the modern scientifically driven or evidence-based psychotherapies, which are interpersonal therapy, cognitive behavioral therapy, acceptance and commitment therapies, ACT, that these therapies, we regularly, when we use these approaches, we regularly are addressing relationships with the patients that we are seeing. And we are regularly trying to improve those relationships in the patients that we are seeing. Oftentimes that change from unhealthy relationship to healthier relationship is actually a part of the therapeutic interaction between therapist and client. And then ideally modeling and showing that healthy way of relating in therapy. And then clients tend to go out and generalize those newfound healthy skills and ways of interacting with the people in their lives. And that oftentimes improves their relationships, okay? We know that we're going to cover this more in social support, but we are interdependent creatures. And we are absolutely wired across human evolution for empathy, and we are wired for relationships. So one piece of evidence that we are wired for relationships is our speech. I mean, think of how valuable our ability to talk and communicate with one another is, that it would be hard. Can you imagine like trying to date or form friendships and not be able to speak with people? That would be so weird. So it's no wonder we've evolved into language and our ability to speak to one another. We are also wired for empathy, and particularly women are wired for more empathy than men. Now, both men and women have empathy, and there's overlap. I'm not trying to stereotype here in any way, but can anybody think of what would be the evolutionary adaptation for women to have more empathy, to be able to read nonverbals and read other people and know what other people are feeling? What would be the evolutionary adaptation for that?
I think that's just maternal instinct.
Yeah.
Like women were just caregivers throughout history.
Yeah, women tend to be caregivers beyond babies, but we think that the adaptation has to do with our babies. Human babies are born with more dependency needs than any other mammal. You know, think about cows and horses, like they're up and running with the crowd, herd. They're up and running with the other cows and horses around them, like within a day. Human babies, they don't walk until, they're past 1 year old. You have to carry them around. And they're not verbal. That's part of what I think happens when you hear about terrible twos and the twos and the threes. They have the language. They've grown enough to have the language to tell you what they want. Oh my gosh, if you don't give them what they want, that's when they just melt down. It's like, I've told you and you're saying no, and they just melt down and kick and scream around on the floor. Yeah, so I mean, you've got these little creatures that have all these needs, and it's no wonder that it's easy for particularly for moms to bond with them and to learn. Oh, that's a I'm bored cry. Oh, that's a I'm something's really wrong cry. Oh, that's a I've got a dirty diaper cry. Oh, that's a I'm hungry cry. That kind of stuff. Of having the empathy to be able to figure out what on earth will keep these little babies alive long enough for them to become verbal and be able to tell you what they want and what they need. So we are wired for empathy, okay? I mean, that is a really beneficial social skill that many of us have, is to be able to kind of read a crowd or read a significant other or read a child and know some sense of what they want and what they need. Then there's this thing, Michelangelo effect, it's sort of after the famous painter, but I want you to take a look at this couple down here. Does anybody in here feel like this couple looks alike a bit? Yeah, they're similar in age, they're similar in race, which there's some of that source of social site selection that does tend to happen for human beings. But some of the Michelangelo phenomenon is that oftentimes individuals who are really close to one another will mimic each other's emotions, and they will even mimic how each other talks. So I find it funny in my family that partners, sons, around my different pets, the pets have different voices, and everybody knows the voice of the different pets and what the different pets say. And so there's a lot of like, people repeating, doing the same emotions and repeating the same little things that the pets say. And then by doing that, everybody's mimicking the same facial expressions. And so the Michelangelo effect is when people do that, they're kind of doing the same kind of nonverbal and facial expressions over and over and over again. Their faces actually wrinkle and age similarly. And so you get these couples that have been together for these long periods of time, and there is an attraction, weirdly, to people who kind of look like us. But then there's also, the more time people spend together, they actually like age and end up looking more and more like one another. So check that out. Think about the couples that that are older, and see, play that game of who looks like each other and who looks very different in terms of relationships. Now, in psychotherapy, we know that 1/3, predicting the outcome of success or not success in psychotherapy, 1/3 of that outcome is this thing called the therapeutic alliance. And that therapeutic alliance is really a measure of how well have that therapist and that client built rapport, built a real relationship, built a genuine but professional therapeutic relationship. And one of the things that most clinical psych programs do, and we do, the school psych program does this too in our department, is not only do we invite people who have the strongest applications to come to our interviews, but we put them through pretty rigorous interviews. And we want to see these individuals. We want to see them face to face. We want to interact with them. And so much of that is we want to get an idea of, do they have social skills? Can they make good eye contact? Do they have good nonverbal expression? Do they have empathy? Do they care about other people, other people's perspective, other people's feelings? Because those social skills are really hard to train. If people naturally have those social skills, that's going to make you all a great healthcare provider, regardless if you go into clinical psych, if you go into dietetics, if you go into physical therapy, athletic training, whatever. Those are really good skills to have. And so we deliberately try to select students who have that on interview, because again, we wouldn't want to take students that struggle with that and are really, really hard to train. We had a couple years ago, as an example, a young man that interviewed back when we had a master's program and not a doctoral program. And this poor fellow, all throughout his interviews, he was obviously very smart from his academic record. He couldn't make eye contact with anybody. He couldn't make eye contact with other applicants, couldn't make eye contact with faculty. And it was just one of those things where it was like, oh, dude, sorry, you need a different career. This is not going to be a good career for you. But anyways, I was trained, and when we train our doctoral students nowadays, we train them in building that rapport, feeling comfortable in their skin, building that rapport, building that relationship, because all of the other therapeutic interventions that we offer, you've got to have that relationship in place first before you can do those interventions and really help that person. So one of the pieces of advice that I tell to you all is that, particularly if you're looking for a psychotherapist, if you go and see somebody and you don't feel comfortable with them, find somebody else. And I say the same thing for any kind of health professional. If you're seeing a medical doctor or a physical therapist and you don't jive with them and you don't feel comfortable around them, and especially if they give you the ibby-jibbies in some way, find somebody else, because so much of your success in whatever they're trying to treat is going to be a function of that positive relationship. Okay, so Bowling Alone, I had not, there's a book called Bowling Alone. I have not read the book, and I had actually not even heard of the term bowling alone until I read this Walsh article. A lot of this other stuff I knew about. But apparently it's a book about this changing trend in what is happening in our society, where more and more people are experiencing social isolation. They've got less time with their family and friends, less intimate contacts, which we know is that best predictor of quality of life, less confidence, less engagement in civic communities, in churches and synagogues and things like that. And so he's coined the term bowling alone, with the idea that usually when you bowl in a group. My parents, when I was younger, they always belonged to bowling leagues, and they had their own bowling ball, and their whole team had the same shirts. And it was this big social event once a week. They would go bowl, compete against other teams, drink beer, have fun. And so people don't tend to do that. You don't see bowling leagues like you used to. So this whole idea of like going and bowling alone is this like the ultimate sad, like, oh my gosh, here's where we have arrived. Some of what he talks about in Bowling Alone is this trend that many of you are actually might be experiencing in the near future, is that one of the best predictors of not living near extended family is going away to college and getting a college degree, because oftentimes that college degree will take you to where the jobs are, which in a lot of cases are not back in hometown or home city around extended family. Okay. The best predictor of remaining around extended family is getting a high school degree or a trade and staying in the community. So college is a risk factor for students ending up tracing the jobs, as an example. I never thought I would end up here. Well, right now I'm in South Carolina, but anyways, never thought I'd end up here in Boone, North Carolina, but that's where the job took me. They needed a health psychologist at Appalachian State years ago. And it was like, I would like a job, please. And I would like an academic job that had a tenure track, please. And so I'm not necessarily living around a extended family because of that. Okay, TLC number 5, recreation and enjoyable activities. And a lot of times this is going to overlap with nature. This is a view of mine in Valley Cruces Park. In the park, you can see the steam coming up off the river. That is the Watauga River. And how many of you, has anybody here been to Watauga, to Valley Cruces Park? Just a shout out for yes, some of you. Okay. It is an absolutely beautiful park. Unfortunately, it's closed right now, trying to reduce. There were a bunch of teenagers that were not social distancing that kept coming into the park, so they had to close it. But we've got some beautiful parks around Boone. We've got out in Todd, there's Todd Valley Park. Valley Cruces Park is absolutely gorgeous. We call it Leo's Park because my dog loves to go walk in that park. Okay, so back to recreation, enjoyable activities. I love this term, recreation. And so recreation for a lot of us recreates, it soothes our souls. It helps us feel like if we've been in those artificial environments on those screens, getting away from that kind of stuff is that kind of recreation, making us feel like, oh, I'm renewed and I feel better. We know that people who have psychological disorders, a simple way of predicting a psychological disorder is people reporting that they've got very little reinforcement in their lives. And we know that engaging in recreation increases that reinforcement in our lives. And that recreation oftentimes will overlap with nature. It'll overlap if you get out in nature with others and you talk about your lives as you socialize, as you are hiking or biking or walking. And then in getting out and having recreation for a lot of us gets us exercise. So this is going to overlap with a lot of those different TLCs. Okay. Some other forms of recreation, engaging in humor. And I know I've learned over time, I've got a whole toolbox of coping skills, and I use that a lot with my clients when whatever ails them. We talk about, you've got to build this tool for this problem, this tool for this problem, this tool for this problem. But I have learned over time that if I have had a really yucky day and I am grumpy, particularly when my boys were in the house, I would go hide, put on stand-up comedy. There was usually a glass of wine involved. And I would just watch stand-up comedy and I would just laugh and I would just get into it and I would lose myself and just laugh and laugh and laugh. And then I would come out of the room that had the TV and the stand-up comedy, a whole new person, much better to be around, much better for people to see me, that type of thing. Other ways that people do recreation is involvement in creativity and involvement in the arts. I hope that many of you, while you have been, particularly if those of you who are fully quarantined, have something creative that you can do to express yourself, because that is really valuable. And there's no wonder that we have these different therapeutic arts. I know we've got at least one music therapy student in our class. Emily, are you? No, Emily couldn't attend today, but we have at least one music therapy student. Also note that the clinical mental health counseling master's program at our university, it's over in the College of Ed. It's not in the College of Arts and Sciences, so it's not in the psych department. It's over in the College of Ed. They offer master's degree in mental health counseling, and they offer tracks in music, dance, and visual arts expressive therapies. So those are individuals who are trained to use those art therapies in actually their counseling and working with their clients. So know about that program. All right, I have noted it is 4 o'clock. So how about we take our 2-minute break, and we'll come back in 2 minutes and we'll resume. Okay, so if you're back, remember to unmute your video. I notice at least one of you has moved outside since since the break, so that's cool. All right, let's keep trucking along. I think we're going to get done early today, so we can have our Thursday, which is our Friday bonus. Let's keep going. So the next TLC is relaxation and stress management. And one of the things, we're going to spend a lot of time on stress and coping in this class, because stress is just such a predictor of poor well-being. But most individuals, because we don't, like, if our parents don't teach us this, if we don't learn it in public schools, and in my experience with public schools is they don't do a very good job of teaching people how to manage stress. Traditional healthcare workers like medical doctors are not very good at helping people learn how to manage their stress. So a lot of people out there don't know how to do that. And modern day stresses are pretty novel. I mean, since a pandemic, it's even more novel nowadays what people are going through and how stressful that is. But when you think about the stuff that we've talked about already in this lecture, spending a lot of time on screens and computers, if you absolutely have to, that's a modern day stressor that your great grandparents didn't have to deal with when they were young individuals. Living away from extended family can be a stressor for a lot of people. I hear about that particular thing a lot more in my friendship groups when my friends have babies. That in the olden days, if you lived in this extended community and you had a baby, aunts and uncles, grandparents, everybody was the kind of there helping out. And then nowadays, a lot of individuals have kind of lost that. I have found it really interesting that most younger people seem to be most socially successful when they find, it's almost like the Friend Show, when they find friends in a community that is almost like an artificial family that helps one another out. A lot of times people have learned, again, they've learned in their family or they've learned from others, their responses to stress are just not skillful. So like, and or could absolutely be self-destructive. So an example of a self-destructive response to stress might be cutting behavior, it might be drugging, it might be drinking in excess. And a lot of people just they have not been taught the skills that we need to know how to manage stress. So when I talk about that toolbox, I do a lot of kind of just teaching people different tools for coping with different kinds of stressors, building that toolbox. And then the challenging part is sending people out there to realize, oh, this is a stressor that requires this tool. This is a stressor that requires this tool. I love how in the Walsh article, he breaks these stress management skills down into different categories. And the first category he talks about is being somatic psychological. And some of the interventions he talks about, well, we'll spend a little bit more time when we cover the stress management lecture, using self-hypnosis to calm oneself, as well as to make suggestions. So like a chronic pain patient, you're going to see this in the New Medicine documentary. There are several examples of chronic pain management where the patients are learning self-hypnosis, how to chill, how to calm down, but then also pay attention to the dimmer switch, how to tick down their pain level. So there's a couple of really good examples in New Medicine on that. Using guided imagery would be closing your eyes, nice breathing, and then imagine you're at a really peaceful place. So it could be on a mountaintop looking over a 3D view. It could be on the beach, lying on a towel, feeling the warmth of the sun, seagulls, the waves coming in. Guided imagery is just when you take your whole mind to a more peaceful place and your body and your mind just follow suit. Progressive muscle relaxation, I've done this with patients and I like this, especially for people who really like active relaxation. What you do in PMR is you tense up muscles, like you start in your head, you tense muscles, you relax, you breathe, tense muscles, you relax, you breathe, and you move all the way down through your body. It's a really good way of easing up muscle tension for individuals. And we know that this stuff is really good at bringing down stress and treating anxiety disorders in people who have anxiety disorders. The second type of stress management that Walsh talks about, he calls it contemplative. And this would be more meditation, which meditation is normally some type of discipline and practice of repetition. So it could be repetition of paying attention to breathe in and out, breathe in and out. People in some situations are meditating and they're using some kind of mantra. So it could be a nonsense mantra like and then they sit sometimes in full lotus position and over and over again, and they realize, oh, I'm having thoughts back to oh, I'm having thought back to that type of thing. A lot of individuals nowadays, it seems to be a fad, but then also I've got a wonderful friend who does some great research on the power of yoga, Dr. Catherine Catone. Yoga can be very relaxing, and we know yoga that has been studied is very good for blood pressure. It is very good to send us into a healing state in our mind and our body. And for a lot of individuals, they kind of come out of doing a yoga practice with a much clearer head, more cognitive capacity, more ability to learn, more compassion for other people. So some wonderful effects. So we know that these types of things are really good at treating insomnia, treating anxiety. There's data on them being effective in treating eating disorders, treating depression, and then all the way up to treating personality disorders like borderline personality disorder. Okay, so the next type of, well, also I want you to acknowledge that a lot of these modern day evidence-based psychotherapies that we do, dialectical behavioral therapy is used very frequently when individuals cannot control their emotions. Their emotions ride really high and really low. These are oftentimes individuals that get desperate and are cutters or may have frequent suicidal ideation. They often have lots of drama and lots of tension in their relationships. And so dialectical behavioral therapy gives individuals really concrete ways of how to self-soothe, how to chill and self-soothe with their contemplative practice. And that is very effective in helping people who ride those roller coasters of emotions. Acceptance and commitment therapy, ACT, as well as cognitive behavioral therapy, CBT. We do a lot of relaxation training and stress management in these modern day therapies. The way I think about modern day therapies, one of the ways, I mean, there's different sort of theoretical pieces to them, and we will cover that when we cover health behavior change next week. But a lot of times it's just practical coping. It's just teaching people practical skills and practical coping, assuming they have not learned these skills, which most people have not, to help individuals lead better lives. So sometimes you're treating psychopathology, sometimes you're just trying to help them lead a more enriched life and build their quality of life. We know that those two types of therapies, if we use those mindfulness treatments, decrease anxiety and depression. They've even been shown to be effective in caregivers, like you'll see in the New Medicine documentary, those caregivers of Alzheimer's patients. That doing these types of therapy increases our sense of empathy and compassion for other people, which is really good for caregivers, because if they get burned out and they get resentful and harsh, that's not going to be good for them. It's not going to be good for the people that they're caretaking on. All this stuff increases that sensitivity, that sense of emotional stability, and helps decrease burnout, which is a high risk thing for people who are caretakers. Okay. And I want you all to know, particularly those of you who are future healthcare providers, there are certain professions that are higher in burnout than others. Psychiatry, as an example, is real high burnout in the medical field relative to the other types of medical practitioners. But it's something that I would like for you all to know, because again, it's that domino effect, that if we can learn as a healthcare provider how to engage in all kinds of nice self-care behavior and take good care of ourselves, and then hopefully take good care of the people, our friends, family, children, whatever are around us, we are going to deliver better care to our patients, and we are more likely to counsel our patients in self-care and doing these kinds of things. So again, domino effect from healthcare provider to patients. Okay, religious and spiritual involvement. And I want to talk a little bit about the difference between religiosity, which is sort of following some type of established programmatic religion, versus spirituality, which would be, this could be a belief in God or Allah, or it could be spirituality, feeling connection with nature. But we know when you look at the scientific research when it comes to spirituality and religion, there's a big divide in how beneficial this stuff is for mental health between if individuals went to a congregation, a church, temple, synagogue that believed in a loving and forgiving God versus if individuals grew up and attended a religious service where they believed in a punishing God. Does that make some sense? Yeah. And the punishing God piece is especially, I've seen this in clients that I have worked with, especially if they were told that we can sin in our thoughts. Because somewhere in all this, we know we can't control our thoughts. And all of us sometimes have really morbid thoughts, and we have really dark thoughts, and we have really quirky, stupid thoughts, and we have sometimes crazy sexual thoughts. But if you were told that just by thinking about things you were sinning, does it make some sense how dangerous that could be to your psychological health? Yeah. Okay. So I want to tell you a story about, he's now the bishop for North Carolina Lutheran Synod. Dr. Tim Smith is our bishop, but he was, I remember he was our pastor for years, and I remember talking with him about mental health needs of people in the congregation. And he was talking about this difference between being a pastor who believes in a loving God versus a pastor that believed in hell and brimstone and God is, punishing you if you were bad. And he told me this story that when he was on his internship, he was the chaplain, an on-call chaplain and in training at Wake Forest Baptist Medical Center. And he gets paged one evening and gets a call in because there's this couple that live nearby. This is every parent's nightmare, where in their driveway, their kid was playing in their driveway, and the dad didn't see the kid, and the dad backed over in his truck, backed over over the kid, and killed their kid. And so Pastor Tim gets called in, and this couple is at Wake Forest. They realize their child is dead, and they're absolutely hysterical. They're crying and they're hysterical. And he comes in to them and he tries to calm them down. And he's like, oh my gosh, God is crying with you. I'm a parent. This is every parent's nightmare. This is so sad. What has happened to you? And he's about to invite them into prayer. At that point in time, their home pastor has been called in, and Pastor Tim describes this. He kind of comes through the door and he instructs the man and the wife. He's like, on your knees now. Obviously, God has punished you. What have you done? Get a little different feel for the different approaches there? Yeah, I would not. If something horrible happened to somebody in my family, that would not be the first spiritual message I wanted to hear, that I had been punished and obviously I'd done something bad. And now I'm supposed to suffer in my punishment because of this bad thing I did. I would want to hear that God is crying with me and trying to hold my family and loves us while we are going through this incredibly painful event. Okay. So different kind of takes on depending on where people have been in their religious involvement. I've worked with clients before who are transitioning, who have been raised in more of a fundamentalist fire and brimstone approach, but then have found or are seeking a new church or synagogue or temple where they want a more loving, caring environment, and they have to undo a little bit of that brainwashing that they feel like they inherited. And it's been really enjoyable working with people going through that transition. Okay, we know this is how powerful the data is, though, folks, that people who attend weekly services on average live 7 years longer than people who do not attend weekly services. So this is a very powerful effect. And there are a lot of individuals, and this makes a lot of sense to me, even as a psychologist, when I think about our frontal lobe and our ability to think abstractly and to think analytically as human beings in comparison to our primate ancestors and friends. We have the ability to think that abstractly, and we have that ability, and we think we're kind of wired to wonder, like, what am I here for? Am I a part of a bigger picture? And I think a lot of us get that in nature. Am I a part of something bigger, or am I just this, you know, organic thing that is a human being here on earth. So it makes a lot of sense that people get a sense of meaning and purpose and connection out of that. We know in the field of psychology, there's this thing called internal locus of control and external locus of control. And I'm going to use grades in the class as an example because as students, I think you can relate to that. So imagine if you are striving to be an A student and you get a C on your first grade in the class. A person with an external locus of control would be, well, the teacher must hate me. Teacher has her favorites and the teacher must hate me and she gave me a C, but I think I deserved an A. A person with an internal locus of control who wanted an A, who got a C, would be like, oh, whoa, I thought I had studied and I thought I knew that information, but apparently I was not doing it quite the right way. I need to change the way I do things and I need to study better. Maybe I need to get together with a study group of my study buddies and do it a little differently. Does that make sense? Internal versus external locus of control? Okay. Usually, psychological health is predicted by internal locus of control. Those people that sort of feel like I am in charge of my destiny to a certain extent, and I take responsibility, and I am conscientious, and if I make mistakes, I try to learn from my mistakes. That internal locus of control normally predicts psychological health, with one exception. And that is having an external locus of control, believing in a higher power, believing in God, Allah. That's the one place where external locus of control tends to benefit our psychological health. Okay? It historically, and we could go out here and we could interview people in the community, like at Walmart or whatnot, and just ask people, do psychologists honor religion? And most people believe that all psychologists are atheists and that all psychologists poo-poo religion. And that is the case in some people who have chosen that profession. But when you start to look at the scientific evidence and realize like, wow, it's really powerful. And there's a bit of a stereotype there for certain healthcare professionals. So there's no wonder that programs like, I know you all in here have heard of Alcoholics Anonymous or Narcotics Anonymous, and then there's Overeaters Anonymous, and there's these different kinds of anonymous groups. Those groups are not professionally led, they are peer-led, and they all have a religious component to them. There's a 12-step component that people who go into AA or NA are supposed to be working through. They get a sponsor, so there's somebody who is further along in their recovery than they are, much further along in their recovery, who've worked those steps. And they get a sponsor assigned to them, and they go to the meetings and they're working the program. But ultimately, in the 12 steps, it is a spiritual program of getting closer to God, getting your life straightened out as you get closer to God, and working those steps and mending relationships, as well as getting sober and staying sober on those programs. So it's no wonder that AA invites this component. Dialectical behavioral therapy, acceptance and commitment therapy, ACT, we're going to talk about this next week, is really values focused, values driven. So it's no wonder that even these modern day psychotherapies very much embrace spiritual involvement and a sense of community in those programs. Okay. TLC number 8, contribution and service. We know that individuals who are more altruistic and who engage in more altruistic behaviors, many of you in here, I know you have altruistic streaks because you are interested in going into healthcare. And we know that people who are altruistic, as long as they are caretaking without burnout, tend to be psychologically healthier. And somewhere in that, it feels good to give. It feels good to help. And it feels good to feel like you've got purpose and meaning in your life if you're that kind of person who likes to do that. Again, as long as you don't cross that line of burnout. Walsh talks a little bit about wounded healers, and I love that kind of thing because a lot of times people have different motivations for going into healthcare with the idea that we've all been wounded, some worse than others. I talked about that poly-victimization a little while ago. Those are individuals who have been extremely wounded when they have experienced that type of victimization. Some of us have light wounds, that type of thing. But the idea that if we have healed from our wounds, or we've had people help us heal from our wounds, wouldn't it be great if we could give back and we could help other people in those situations with their life situations? We know that people who volunteer, particularly after they retire and engage in volunteering behavior, they tend to lead healthier and longer lives, probably because it feels good to give and help. We know that all of these modern day therapies, cognitive behavioral therapy, dialectical behavior therapy, acceptance commitment, try to get clients involved and get them out there helping, because that helps them feel better about themselves. I had a young teenage client a couple of years ago who had made great improvements in therapy across the 2 semesters, but she was dreading summer coming on because she was too young to work. She's too young to get a work permit. Both of her parents worked. Her sibling annoyed her. And so she was dreading summer vacation, where she was stuck at home with an annoying sibling with nothing to do, no schoolwork to work on. And we had to really start brainstorming, like, okay, what are we going to do to prepare you for your summer? How can we get you into summertime where you feel like you've got more meaningful stuff to do? And what she ended up doing after we looked at her interests is she ended up training at the local humane center and spent her summer. Her parents would take turns dropping her off at the humane center. So she would play with the kittens and the puppies and the dogs and the cats and help take care of them and help give them basic training and help people find what pets they wanted for adoption. And she found that to be tremendously fulfilling for her summer. It like filled the space where she was, able to be around animals that she loved, and she was able to be helping much better than sitting at home bored with an annoying sibling and not having anything to do, as an example. We've got to be careful about caretaker burnout. We've talked already a bit about that. Just the pressure, that sense of duty. If it feels like it is duty that you are choosing, that is so different than obligation and duty that you are being forced into doing. I've got this picture down here. This was a picture floating around. This is a nurse, and I believe she was one of the nurses from Alabama that got sent up to New York City. And she had just come off a tremendous shift working with all these COVID patients. And you see how layered she is in her personal protective equipment. I look at that. I just look at the equipment on her and I just feel hot. Like, oh my gosh, how hot and miserable that must be. And she saw patient after patient after patient after patient die that day. And so it's just sort of an homage to some of these healthcare workers that are on the front lines that are engaging in incredible service right now and taking care of people. And my prediction is we're going to see a lot of healthcare workers burnt out, leaving the profession. We psychologists, there's a lot of discussion on a listserv, and I'm actually taking a continuing education course right now, know that we're going to be dealing with a lot of healthcare workers with PTSD here in the near future. And how do we get ourselves ready to start treating these individuals who can no longer function because of their PTSD, or their lives have been turned upside down, or their relationships have been turned upside down because of PTSD, where normally you get that stuff going off to war, or you get that stuff when you've been a victim of violence. But in this situation, I think it's going to be one of the earliest times in our modern history where we're seeing it in our healthcare workers who are literally at war out there serving people who are very sick. Okay, so the next thing in line is, I'm not going to play this today because you've got the link, the New Medicine documentary. Pay attention to the cases, okay? Pay attention to the patient cases. Try to remember their names, because that will help you remember their stories. And then pay attention to what the different psychologists and medical doctors are doing in either training their students in serving these patients, what they are doing directly to serve these patients. It's very memorable. So if you just watch this documentary and you pay close attention and take some real brief notes on the different cases, it will be easy for you to remember. Any questions about what we've covered today, or any questions about the New Medicine documentary? Are you all ready to move into your weekend?
Yes.
Yay. Okay. Thursday is the new Friday, so the weekend has started. After, I hope you don't have an evening class. This is usually the last class of the day in summer school. So congratulations for making it through the first week. If any of you all have any questions after we get done here today, shoot me emails. I'm on email every day, so I can respond. I will probably set up a office hours drop-in sort of study thing next week. If you want to drop in on Zoom and ask questions as you are studying, getting prepared for the first exam, which is next Thursday. So we will have live class and lecture Monday, Tuesday, and Wednesday. And then your exam will be due by Thursday at class time. So feel free to contact me if you've got any lingering questions. All right, otherwise, y'all have a great weekend. It's good seeing everybody. Take care.